Welcome to part 2 of aging. This is going to focus on elder abuse. Elder abuse is defined as harm caused through physical abuse, neglect, intimidation, cruel punishment, financial abuse, abandonment, or deprivation by a caregiver of goods or services that are necessary to avoid physical harm or mental suffering of an elderly adult. Elder abuse may be domestic or institutional, meaning it can occur at home or in any type of facility. It's estimated that 1 in 10 older adults over the age of 60 are abused, and 58% of those cases are abused by someone they personally know. Unfortunately, only 1 out of every 23 cases of elder abuse are reported to the appropriate authorities. There are different types of elder abuse. First, there's physical abuse, which is the intentional use of physical force that causes mental or physical injury. This could include hitting, slapping, restraining, incorrect positioning, over-sedation with medications, or inappropriate use of medications. There can be sexual abuse, which would be forced or unwanted sexual interaction of any kind with an older adult, including non-touching sexual acts like pornography or forced pornography. Sexual abuse is the most underreported type of abuse. Psychosocial or emotional abuse includes verbal or nonverbal behavior that results in mental pain, anguish, fear, and distress, and could cause humiliation and threats of violence and isolation. This type of abuse is hard to detect because there aren't physical signs we can spot. Financial exploitation or financial abuse involves illegal or unauthorized use of a financial resource by the caregiver or trusted person. This could be that the abuser is stealing, like their Social Security checks or their retirement savings, to using money from their checking accounts to buy themselves things and not things for the elderly person whose money it is. And lastly, we have neglect. This is the most common type of elder abuse, and it involves failure by the caregiver to provide the necessary medical care, nutrition, hydration, and activities of daily living required by the elderly person. Neglect can be active or passive. Active neglect is the malicious withholding of basic life necessities, which can include undermedicating. They're choosing to be neglectful. Then there is passive neglect, and this is when a well-intended caregiver is incapable of meeting the needs of the elder. They want to do the best that they can, but they may not be physically or financially able to do so, and may not even know what resources are out there to help them. We see this a lot, and it can be very devastating for us as nurses because we see the patient, we see them with pressure injuries and skin breakdowns and malnutrition, but we also see the caregiver who is trying as hard as they can to take care of the person. When we look at who's at highest risk for being abused, research shows that predominantly women are abused more than men. We also know that older adults over the age of 75 are at higher risk of being abused. Older adults who have impaired functional and cognitive abilities are more abused, as well as older adults with more chronic or debilitating illnesses, including depression. Older adults with lower education levels, especially less than an 8th grade education level, and those living in poverty are at higher risk of abuse. And all minority older adults are at high risk of abuse. So the question is why? People in these groups are usually dependent upon someone to help them. They're in a place of lesser power, and abusers see that place of power and dominance, and they use it to abuse. And older adults are less likely to say anything to other people about being abused because they're scared, they're fearful of the abuser, and they're embarrassed, especially if it's a loved one who's doing the abusing. Also, older adults are not out and about as much as younger and middle-aged adults, so it's much easier to hide the abuse from other people. Indications for abuse are often misinterpreted as normal signs of aging, but if healthcare providers have careful observation of the relationship between older adults and their caregivers and look for signs of abuse, we may be able to see the abuse and stop it. When we look for abuse, we want to look for unexplained bruises and trauma. We do need to be mindful that people who take blood thinners and prednisone are at higher risk of bruising. So people who take those medications may have those unexpected bruises as a side effect and not as abuse. We need to look for signs of physical neglect, like pressure injuries and skin breakdown, unwashed body, hair, and mouths. The clothes may be dirty and smell, and the patient may look like no one's been caring for them. People being abused may have excessive anxiety, either when the abuser is present or when they leave. When they are present, the anxiety may be caused by the abused person knowing that the abuse could occur at any moment. If the anxiety is after the abuser leaves, it may be because they're anxious because the person is gone and they know that when they get back, they're going to be abused or mistreated by being asked repeatedly if they told anyone about the abuse. The person being abused may also be excessively withdrawn and fearful of answering questions and may defer all their questions to the abuser. Some physical signs and symptoms of abuse include bruises in various stages of healing, black eyes, fractures, burns, and pressure injuries. We do need to do some careful observation and questioning, as disease processes like limited mobility that can cause falls, which can cause bruises and fractures, does not mean physical abuse. Sometimes people just fall. And with burns, you may see small little cigarette burns in easily hidden areas like the armpits, the groin, and the feet. When we suspect abuse, we must do a careful and thorough head-to-toe assessment, preferably without the abuser present. We may have to get creative and work with other departments to get the abuser out of the room. It's unlikely the abused person will admit abuse while the abuser is standing right there. If you suspect abuse, you need to follow your facility's policies and procedure on who in the facility you notify first, but just know that all suspected abuse must be reported immediately. This is the law. Nurses are mandatory reporters for abuse. 911 should be called if the patient is in imminent danger, and the State Health and Human Services Department should be contacted for anyone who lives at a facility. Adult Protective Services should be contacted for patients who live at home. APS will investigate the report of abuse and discuss alternatives or possibly remove the patient. However, if the patient is alert and oriented and chooses to remain in an abusive situation, very little can be done. But the number one thing we need to do is to treat the patient with trust, dignity, and respect. The last thing an abused person needs to hear is the nurse speaking down to them, telling them that they're making a mistake for not saying anything or for covering up for their abuser. That's abuse all over again. When we document suspected abuse, we must be very objective. What we saw, what we witnessed, the things that were said to us must be in quotes. We must include observations we made while the abuser was with the patient and when the abuser was not with the patient. If your policy allows it, you may need to photograph physical abuse. We already know that documentation is important, but abuse is a legal matter. What we document may go to court and may be used against the abuser, so we need to make sure every single thing we saw and heard is documented to give the abused person the best chance of getting out of that abusive situation and for the abuser to be brought to justice. And this is the end of part 2 of aging.